the Special Joint Committee on Medical Assistance in Dying. I'd like to begin by welcoming members of the committee, witnesses, and all those watching this meeting on the web. My name is Marc Garneau, and I am the co-chair of for the House of Commons of this committee. I am with Marie-Françoise Migy this evening, who is Vice Chair, Senate.
Our examination of the statutory review of the provisions of the Criminal Code relating to medical assistance in dying and their application. I'd like to remind members and witnesses to keep their microphones muted unless recognized by name by the chair. A reminder that all comments should be addressed through one of the chairs. When speaking, please speak slowly and clearly. Interpretation in this video conference will work like an in-person committee meeting. You have the choice at the bottom of your screen on the interpretation button of listening either to the floor, English, or French. With that, I would like to welcome our witnesses for panel one who are here to discuss advance requests. As an individual, we have Adelina Iften, who is a law professor. Et nous avons également le docteur.
We also have Dr. David Lucier, physician, geriatrician, assisting by video conference, as well as Dr. Félix Pajot, physician, geriatrician, and researcher. Thank you all for joining us. We'll begin with opening remarks by Ms. Iftin, followed by Dr. Lucier, and then Dr. Pajot.
Iftin, you have the floor for your opening statement. You have 5 minutes. Please go ahead.
The Joint Committee, thank you so much for the invitation to make submission before you today. As I mentioned in my correspondence with the committee's clerk, my expertise is actually not in advance directives or MAID generally, but rather it is in corrections, healthcare law and policy for incarcerated people, and issues surrounding decarceration. Hence, my comments today pertain specifically to the issues raised by the
Rappel au règlement, Monsieur le Président.
Point of order. We are not hearing the interpreting.
Sorry, witness.
Pardon, to the witness, we'll just hold a second because we're not getting the proper translation. Mr. Clerk, let me know when the translation is provided so that we can continue.
On nous dit que ça fonctionne, Monsieur le Co-président.
Mr. Co-Chair, we're told that it's working now.
And I think we've resolved our translation problem, so please continue.
My expertise is not in advance directives generally or in MAID broadly, but rather it is in corrections, healthcare law and policy for incarcerated people, and issues surrounding decarceration. So my comments today pertain specifically to the issues raised by the implementation of MAID in prisons, issues which should be prioritized in the review of the MAID legislation. The conversation so far around MAID in prison has largely been reduced to dichotomy solutions. Should incarcerated people have access to MAID? Should the MAID procedure take place in the correctional institution, or should it take place somewhere in the community? And I want to be clear, to the extent to which and in the circumstances in which MAID is a healthcare service in Canada, based on the nationally and internationally protected principle of equivalence of care, it must also be available in the same conditions to people that are incarcerated. However, this answer oversimplifies matters. And it does so because the question it answers entirely misses the point of the problem of illness and death in prison. It is well known that healthcare in prisons, basic, specialized healthcare, and especially palliative care and long-term care are deeply inadequate and often fail to meet any community standards. I and others, especially the Office of the Correctional Investigator, have long documented the systemic healthcare inadequacies, and I don't think this can be the subject of a reasonable informed debate any longer. It is clear that Canada does not have a functional compassionate release mechanism. Section 121 of the Corrections and Conditional Release Act, the parole by exception provision, has been used 20 times over 10 years prior to the COVID pandemic, and it cannot generally be used for those serving life sentences. At the same time, during the same period of time, 30 to 40 people have died annually of natural expected death in prisons. The use and availability of Section 121 has not improved in light of the implementation of MAID in prisons a few years back. The reality is that in a country where there is no death penalty, there is no life sentence without possibility of release, the number one cause of death in prisons is natural death occurring at the end of an often known illness for which the individual had limited, if any, adequate treatment options. If the only consistent and realistic option for this suffering is MAID, Canadian sentences are becoming de facto death sentences. It is unacceptable that it is easier to obtain MAID when one is in custody than to obtain any type of compassionate release. For instance, a person serving life is not eligible to even apply for parole by exception unless they are within weeks of dying. That we know is not the case with MAID. And for a discussion on these issues as well, and for a discussion on compassionate release and the way it works in Canada, I would like to draw your attention to the articles that I've wrote or co-written with Professor Jocelyn Downey and which I submitted to you in advance. The issue with the fact that there is easier access to MAID than to release is not, I submitted with MAID. Simply prohibiting MAID for those incarcerated or making it harder to access is not a solution to the lack of choice, dignity, and autonomy of those in prison, and it is also inconsistent with the equivalence of care obligation. Letting people suffer is not enhancing their dignity or autonomy. So the problem is not with MAID being available to prisoners. The problem is with the lack of adequate release mechanisms and supports. Everyone who has a serious life-limiting illness or is in intolerable suffering should be eligible for consideration for some working form of compassionate release. Compassionate release needs to be available not just so the individual can receive the MAID procedure in the community, but so they can make all end-of-life decisions in the community, whether those include MAID or not. The discussion about a substantial reform of release mechanisms, which includes eligibility to be considered for release, the factors that are relevant to the release decision, and the expertise of the members of the parole board on these issues, these are all discussions that are inherently linked to the broader discussion on the implementation of MAID in prisons. Meaningful amendments to the MAID legislation must consider those in custody. And as a result, it will have to ensure that people in custody have realistic options for release to community where they can freely make informed end-of-life decisions. To conclude, I would like to mention that there are a number of outstanding issues with MAID, in addition to the issue of lack of other options, including palliative care and release. These include the Correctional Services exemption from reviewing and investigated MAID death, which are linked to a lack of adequate oversight and the role of prison physicians, the role that they have in the assessment process. I would be happy to address those issues during the question period. Thank you.
Thank you, Ms. Iften. We'll now go to our second witness, Monsieur le Docteur David Lucier. À vous la parole.
Over to our second witness, Dr. David Lucier. You have 5 minutes. Thank you, Co-Chair. Thank you for inviting me to discuss this very important topic. A few words of introduction. I'm a geriatrician. I work at the Institut universitaire de gériatrie de Montréal, du CIUS du Centre-Sud de l'île de Montréal, Montreal Geriatrics Center. I have also training in pain and palliative care, and for the last 20 years, my practice has been nearly exclusively in the management of chronic pain for the elderly. I have been interested in medical assistance in dying as soon as this began, and since this began in Quebec. I'm a member of Quebec's Commission on End-of-Life Care, but I am not speaking on their behalf. I'm here on my own behalf. I have been practicing medical assistance in dying roughly 1 to 2 times per month in recent months, sometimes for patients that I have been following for a long time, but sometimes for patients for whom I'm asked to consult. Because of my clinical expertise, the people that I assess are usually people whose eligibility is not clear, with not reasonably foreseeable natural death. Some of them have major neurocognitive disorders. I have given conferences on medical assistance in dying fairly regularly to health professionals and the general population. The most important points for advance requests for medical assistance in dying for people suffering from major neurocognitive disorders are the following. First of all, obviously, I cannot talk about Canadians opinions across the country. But according to testimony received in Quebec's Special Parliamentary Commission at the Quebec's National Assembly last fall, and the testimonies that I have heard when I was giving conferences or in my practice, I believe in Quebec there's fairly broad acceptance for early requests, advance requests, in the general population, as well as those suffering from major neurocognitive disorders and their families. There is a fairly broad acceptance from health professionals as well, even if some people see that there could be difficulties in application. In Quebec, the population agrees that medical assistance in dying could be extended through early demand advance request. Several were disappointed when the bill to this effect was abandoned in the spring. In the current situation, since the reasonably foreseeable death criteria was withdrawn, people with major neurocognitive disorders can be eligible and receive medical assistance in dying. There is a small window in the evolution of the disease where the disease is bad enough for there to be an irreversible decline in capacity, but not be bad enough to compromise the ability to request MAID. In my experience, people with major neurocognitive disorders often wait as long as possible, sometimes just before losing their capacity, so that a 90-day time frame can be shortened because the loss of capacity is imminent. If they could make an advance request, several would probably not choose medical assistance in dying right now to be able to continue enjoying life with their loved ones. But now they are dying earlier than they would have wished. So their right to life, as guaranteed by Section 7 of the Canadian Charter of Rights and Freedoms, is not being respected, as the Supreme Court had judged in Carter. Because in order to be able to benefit from medical assistance in dying and not experience their decline right to the very end, they have to die earlier than they would have wished. I believe the law should be amended so as to allow people with major neurocognitive disorders to be able to make an advance request for MAID. This is a complex issue, both ethically and in application. First of all, it's hard to assess suffering, which is subjective, and it's hard to assess that in somebody who is unable to communicate. In some cases, there's undeniable objective suffering with nonverbal signs of being in pain or psychological symptoms or behavior associated with dementia, such as aggressiveness. But in other cases, people seem to be in happy dementia, as one could call it. The person seems happy on a day-to-day basis, even though there's a loss of independence and major cognitive disorders. But if they saw themselves in this state, perhaps they wouldn't want to be experiencing it and living like that. The eligibility criteria, should the eligibility criteria be contemporaneous suffering or advanced suffering? That's an important issue. Another issue could be the refusal by the person who had requested early MAID to collaborate when the time comes. Some people in advanced stages don't accept any touch or any contact. They become aggressive. So they would have to be restrained because they wouldn't, or sedated because otherwise they wouldn't accept intravenous. And if the person had their capacities, they probably would have wished to be sedated or restrained to be able to receive medical assistance in dying. But should you ignore their refusal, which is verbal or physical, when they're no longer having their capacities? Several clinicians say that they would have trouble doing this. Thank you for allowing me to discuss this early request for an advance request for medical assistance in dying. Guidelines, of course, should be clear to help support clinicians who would be involved at the time of the application or request, as well as at the time of administration. Thank you very much. And now, Dr. Pajot, 5 minutes. Thank you. I'm a doctor and a researcher as well as a geriatrician. And I know my colleague, Dr. Lucier, very well, but I don't always agree with him. And I'll tell you why. Sorry if I have a bit of a hoarse voice. I have a cold. So it may be a little bit hard for the translators. First of all, I'd like to express my recognition and gratefulness. This is perhaps philosophical and ethical, but I'd like to be a little more practical than I have been in the past. We know that a physician's responsibility is to respect his patients. Our government also has to protect vulnerable people and protect people from themselves. We see that with the legal age for drinking alcohol and the whole concept of wearing helmets when you ride a motorcycle, etc. Freedom is not absolute in Canada. So I have 3 clarifications or recommendations to propose. First, I have 3 comments. The error by individuals who are filling out the advance request forms, the errors in people who apply them, and then other questions related to the advance directives related to major neurocognitive disorders. First of all, people don't have crystal balls and don't know what the future holds in store for them. They have to imagine themselves, but you have to look at their current state. So if you can have a dementia specialist, you have geriatricians and orthopsychiatrists or family doctors who see a lot of these patients. We're going to have to open medical assistance in dying clinics. Do we have resources to do this? At the same time, could doctors be paternalistic in dealing with their patients? Autonomy will not be fully respected. And then there's another argument. When you get a major neurocognitive disorder diagnosis, people say this changes a person. Even families tell us this. Sometimes people say, I can't recognize the people around me. This is no longer the person she used to be. There are major changes. Is this what the person said 20 years ago? Is this what should be applying today when they said something 20 years ago? But what about today? In application, there can be several errors. For example, any written text requires interpretation, whether we're talking about literature, text messages, or laws. If the person's not there to tell us exactly what they meant, we have to interpret, but that interpretation can be mistaken. Either it won't be applicable, and we see this in the Netherlands, where advanced directives are not applied or applicable, or conversely, there's a danger that they'll be applied too frequently, and there are conflicts of interest among either doctors or family members. Questions of inheritance, for example, a wish to be free of patients with major neurocognitive disorders. There's a bit of paternalistic expertise here, sometimes when the family and the team decide instead of the patient deciding. And if there's no refusal, does that mean consent? Yes, yes. What does that mean? If someone says, yes, yes, I don't want you to remove my uterus, should we remove it? Did the person really understand? This is not resolved with advance requests. And implicit consent, implied consent, is not consent. On a society basis, there's a more of a philosophical argument. People are afraid of having mental illness because of the stigmatization of major neurocognitive disorders and the associated handicaps and behavior and psychological symptoms associated. So people are afraid of dementia, and so people could be projecting themselves into the future, and because of that discrimination, they don't want to be those people who are not taken care of. Now, medical assistance in dying, and when we talk about advanced directives, there's a difference between requiring assistance or medical assistance in dying. There can be refusal of care. Medical assistance in dying is not a withdrawal of care, similar between first-degree murder or an accident causing death. Intention is what counts. In advance requests or in withdrawal of care, the intentions are different. In terms of recommendations, I think that the government should protect the most vulnerable people, increase care, support in gerontology and for palliative care, and avoid at all costs dementia phobia. And there are certain people who are now defending medical assistance in dying. Thank you very much, Dr. Pajot. Over to questions now. I'd like to turn the mic to my colleague, Senator Mégy. Thank you, Chair, Co-Chair. I'm Marie-Françoise Mégy, Quebec Senator, and Vice Chair of Senate for this committee. Beginning the questions, we'll begin with Mr. Ellis. 5 minutes.
Well, thank you, Chair, and thank you to the other committee members for allowing me to be here and to be part of this fascinating conversation, and to the witnesses for being here this evening as well. Just to clarify, and I may, through you, Chair, have the name wrong, Ms. Liften. I wonder if you might just clarify, is your assertion that because the penal system has such terribly poor conditions and access to medical care that is that the reason why MAID should be a part of the prison system? I wasn't quite clear on what your point was. If you could clarify that, please.
Point. It is not because the penal system has poor condition. It is because of a right that's called the equivalence of care. And as a result, all healthcare services that are provided in the community must be available in prison. That is not the case, unfortunately, with a lot of we know that there is substandard healthcare provided in prisons. So my argument was that the solution and of course there is no real systemic palliative care available. Again, that all those lacks, all those absences are breaching the requirement for equivalence of care between prison and community. And and just prohibiting MAID in prisons is just one more failure on that part. So from that perspective, I think that from an international and national standards, we have to provide prisoners with all the healthcare services that are available in the community. But I think that the conversation is more complicated when it comes to people in custody, simply because there are concerns regarding their ability to provide consent on a free basis. So I think that as long as we do not have working compassionate mechanisms for individuals that are experiencing limiting life circumstances or intolerable suffering, which a lot of times is also associated with a very significant decrease in risk. So as long as we don't have release mechanisms that allows them the option to go and make to be transferred to community, to make end-of-life decision in the community, I think this conversation is going to be very complicated. And I think it does raise issues.
Thank you, Ms. Lieutenant. I appreciate that. Part of the difficulty, of course, then remains without appropriate medical care in the penal system, that moving on to adding things like MAID, to me, would seem to be somewhat difficult. But thank you for that. Through you, Chair, to Dr. Lussier, if I may, you talked about this obviously being very difficult, and I think your colleague, Dr. Pajot, perhaps brought some of the difficulties forward with respect to that, and it would appear perhaps you have different ideas. But I wonder, Dr. Lussier, if you might comment on the length of time between making an advance directive and, of course, coming to that point in your life where it may be required. Is there difficulties with respect to that, please, sir, if you might, and what safeguards might be needed to look at those things?
Well, I think one of the safeguards has to be that you have to make sure that the person is aware of his or her diagnosis. This is why, for example, in Quebec, when this was discussed, it's always been said that it should be done after the person has been diagnosed with major neurocognitive disorder. So I today couldn't do an advance request for medical assistance in dying because I don't have any diagnosis for neurocognitive disorder. So the person has to be aware. And the other safeguard would be that it would have to be reassessed. So it would have to be reiterated several times in the process. So you can't just do it once and then it's applied or it's implemented 5-7 years later. It would have to be reassessed and repeated several times to make sure that the person still wants the same thing.
Thank you, sir. And through you, Chair, are there any safeguards to you, Dr. Pajot? Are there any safeguards that you might think would be beneficial here?
Il faut s'assurer que les gens qui ont des troubles neuro...
You have to be sure that people with major neurocognitive disorders don't ask for MAID because they're afraid of declining or becoming a burden to their loved ones. And that's what we often hear. Often they're afraid when they get a diagnosis. They're often diagnosed and given the option of MAID right away. If they were to be given the option of MAID right away, is the patient going to think, well, is this what the doctor thinks is sufficient to ask for medical assistance in dying? Imagine if you have diabetes and someone says, oh, you have diabetes, would you like medical assistance in dying? Maybe they think that that's so serious. And now the floor goes to Mr. Arsenault. Thank you, Vice Co-Chair. My first question is for Dr. Lussier. I would like to piggyback on what my colleague, Mr. Ellis, just asked. You had a very nice way of describing it. You said that with cognitive disorders, there was a small window that opened during which, at the beginning of the early stages of the diagnosis, there's still a possibility for a patient to be able to judge and have a clear mind to be able to request medical assistance in dying. Did I understand that correctly? I was talking about the current situation where there is a window during which the disease is severe enough. You know that it's a advanced decline, it's serious, and that meets the current criteria. So right now there are people who have neurocognitive disorders who can receive medical assistance in dying. It's already being done. Several people have had this every year. Yes, but do you have safeguards to suggest regarding these cases? Is this something that it can be improved, or should we be more cautious, or are things okay this way? Well, I think what we have to be sure of is, and this would be for whomever medical assistance in dying is available to, we have to be sure that MAID is never requested because appropriate care isn't available. Medical assistance in dying should not be chosen because somebody suffering from neurocognitive disorders can't access appropriate care. And that applies to everything. That applies to cancer or for any other disease. And it also applies to neurocognitive diseases currently. The person has to be appropriately diagnosed and have the right support when they're making the request, and for it not to be something that's being done and taken lightly just because there's no other option for care. Well, yes, of course, that's a safeguard, but I'm not in the healthcare milieu myself, but we've heard all kinds of witnesses for some time now. I didn't get the impression of hearing witnesses who were saying that the fact that somebody wasn't getting sufficient care and they were getting the suggestion of MAID. Have you seen this happen, actually? No, not in my experience. And everything that I've heard about in all the various places. But no, it's not for want of care. We see this in the statistics on palliative care. Most people already had access to palliative care. I think if we want to extend this to other people, we have to be sure that this is the case. Dr. Pajot, along the same lines, in your experience, have you, as a physician, seen people who said, okay, there's no appropriate doctor to take care of you, so we'll offer you a medical assistance in dying? Have you witnessed this kind of case? Well, often people will say, I don't want to be a burden. There aren't sufficient. Sorry, I don't have a lot of time. I'm not talking about from the patient's point of view. I'm talking about from your profession's point of view. Have you seen professionals administer medical assistance in dying in these cases? Yes. In my research for my master's, we heard that this was the case in one case. You used this case in your master's? At least one case. Do you have statistics that could indicate to us that this practice is common, or is this something that's occurred several times? Well, in the Quebec data, one of the first reasons for asking for medical assistance in dying is finding that there aren't appropriate services or care. That's the perception of the patient. My question is from the point of view of the profession. We heard a lot of professionals come to talk to us about safeguards. It's not my impression that in the profession, regardless of which province in Canada they are in, correct me if I'm wrong, health professionals haven't said, oh, we don't have the right specialists, so if you want medical assistance in dying, we'll give it to you. I'm asking from the point of view of the profession, have you seen professionals, your peers, physicians, those who administer medical assistance in dying because there weren't available cares? Well, it's insidious, as I said, very insidious, because the lack of resources make people accept providing this care because this is a situation. Is this recognized by the profession? Well, social suffering is a frequent reason for asking for MAID, and pain and psychological care is also low. Often it's social suffering. People will not say it in the way you said it because, there's a lack of awareness. I'm sorry, Dr. Pajot, I have very little time. I only have 5 seconds left. I'm aware of this. Madam Vice Chair, could you send us your master's thesis, please, through our clerk? Yes. Thank you very much. That's all the time. Thank you to all witnesses. Now over to Mr. Luc Thériault, 5 minutes. Thank you, Madam Co-Chair. Dr. Lucier. You talked about the right to life related to Carter. And this argument In other words, people who are obliged to end their lives prematurely via suicide, for example. This is also in Baudouin, in the Baudouin ruling. When you meet a patient and you tell that patient, well, you're dealing with a major neurocognitive disorder, in the same sentence as Dr. Pajot was saying, do you say, would you like medical assistance in dying? No, obviously not. Right now, this wouldn't be possible because the person has to be in a state of advanced decline to be eligible, so you can't do it now. What you can say when you diagnose, you can be sure that the person has a mandate in case of incapacity, that that person has prepared a will, that all of these precautions for management are either done or will be, have been done or will be done. But in the same sentence, we're not going to say, or even in the same meeting, we won't talk about medical assistance in dying. There's a major debate in the medical profession on that very subject. Should medical assistance in dying be proposed as one of the therapeutic options for someone who is clearly eligible, or should we not? There is no consensus on the matter. I am of the school that we have to wait for the request to come from the individual rather than propose it as a therapeutic option. That's a point of view that can be criticized, but it's my point of view. In your practice, is it frequent that patients open up this conversation and suggest this, given that everybody wants to live as long as possible, but nobody wants to go beyond what they find tolerable? Patients are always the ones who open the door in my case. Several of my patients opened that door who said they wanted to die. Some people had neurocognitive disorders. Others had other pathologies. Several won't want medical assistance in dying, but that's just, to say they want particular care for a particular problem. Some people will ask for medical assistance in dying. It always comes from the individual. Because what I meant earlier is people want to wait as long as possible. So they wait until the very, very last minute. And sometimes when they feel that their mind is going completely, they realize now's the time, because if I wait another 2 or 3 months, maybe I won't be able to have the capacity and I won't be able to obtain medical assistance in dying. So if they could do this in advance, that would avoid this distress and this concern, and they could, in fact, continue to live longer. You were talking about the fact that just because I solemnly in a meeting to this effect identified a third party and identified that I did want to use medical assistance in dying at an appropriate time, that doesn't mean that shouldn't be reassessed in time. The measure is that you have to have reassessment, and this throughout the patient's progress until a third party asks the care team to assess the patient's condition. In other words, this is something that has to be done on a repeated basis. In your experience, is this a case-by-case phenomenon, or how many stages should there be? How many times should this be done? Well, this is very difficult to say. It really depends on the course of the situation. Often you can think about Alzheimer's, where you see a gradual decline. Other kinds of neurocognitive disorders progress much less gradually. As Alzheimer's, it could last several years, or sometimes it could only be a year or two for other types of dementia. And that happy dementia you referred to, in your personal experience, isn't the third party, therefore, the key party in this? If the third party doesn't start the process or doesn't ask the care team to assess, I thought this was relevant for everybody. Well, your time is up. Perhaps somebody else could continue this. Mr. McGregor, your turn, 5 minutes.
Direct my questions to Dr. Pajot. In your opening remarks, you hit on two items. First of all, there can be problems with errors in interpreting the written instructions from a patient, especially when that patient has lost capacity to help someone interpret what they originally meant. And you also mentioned that there is a stigma associated with dementia. I wanted to ask you about those 2 points because we've had previous witnesses who said that there ought to be a requirement for objectively accessible criteria which can be very clearly understood. Like, for example, when I reach a certain stage in dementia, this is what I would like to happen. And second of all, I understand, yes, there is a stigma out there with Alzheimer's. It's not very clearly understood. But to take a different side, is it not paternalistic of us to assess someone's feelings about dementia, especially if that person has once lived with a family member who had dementia, understands the disease intimately, and also understands what is coming their way? I'd just like to hear your feedback on those 2 points, please.
Oui, ben effectivement, c'est la question de l'interprétation. Puis
Well, yes, it's the interpretation of a third party who has to initiate the request, and the doctor has to say, yes, this is a valid request. The criteria are not recognized in the family, incontinence. Those could happen early in dementia. The person could be happy. I mean, the term dementia, some people don't want to use that term because it's so pejorative for others. So there's really dementia phobia in society. So those two elements and the unease to waiting for the patient to request it. I don't wait for a patient to ask for antibiotics if they have infection. I know that it's the treatment, so I suggest it and they can accept or not. If there's a good treatment, I could propose it. I don't have to wait for someone to ask for it. So this unease is interesting to note when it comes to medical assistance in dying. If you have to wait for someone to ask for it, maybe it's because we don't feel comfortable offering it. Why aren't we comfortable? Well, maybe that's part of this dementia phobia, because dementia is a scary term. Some people decided we're going to call it major neurocognitive disorders. So stigmatization of dementia is a known fact, and it's present. And when the person is in an advanced state and the family medical team have to make a decision as to whether or not this applies, the fact that the person can't recognize their loved ones, does that mean that there's enough suffering? This could be a dementia-phobic criterion.
I'd like to turn my next question to Professor Ifteen. Thank you for sharing a perspective which I don't think has often been talked about the experience that inmates have in our federal prisons. And over the summer, I actually got to visit 2 of our federal institutions in British Columbia, so that was a big learning experience for myself. But you have centered a lot of your remarks on the substandard medical care that is available to inmates in federal institutions. And I'm just wondering if you could, for patients who might be in a maximum security prison, serving time for a very, very, very serious crime, so we're talking about, life imprisonment, when they start exhibiting symptoms of dementia and obviously are unable to comply with a regular prison routine, even interactions with the guards or with other inmates, generally, how does that patient progress? Do they go to a lesser security facility? Can you maybe talk a little bit about that for inmates who are diagnosed with those neurocognitive disorders and start exhibiting some of those symptoms?
It's very difficult. A lot of times dementia in prisons and really any other major cognitive impairment is difficult. It's misdiagnosed a lot of times. A lot of times, because the first responders tend to be officers, so they obviously do not have any expertise in this. Even the prison physician that might have access to seeing these people does not have the expertise necessary in diagnosing these issues. So what we end up seeing a lot of times is people that may have had dementia for a number of years, but they were misdiagnosed as having alcohol withdrawal. That's a very common thing that we see, or having behavioral issues as just being misbehaving and being sent into various forms. Now it's structured intervention units, but it used to be solitary confinement or other things like that. In fact, I've seen people with dementia moved from minimum security because they were actually serving life. They were moved from minimum security institutions, not because their risk has increased.
I'm sorry to cut you off, but the 5 minutes are up. And now the floor goes to our colleague, Mr. Garneau. Thank you, Senator. And now questions from senators. Unfortunately, I can't see the room. I'll begin by presuming that Senator Kutcher is there.
Il n'est pas là. Voilà.
He's not there. Okay. Senator Dalphond, 3 minutes. My questions are for Dr. Lucier. I understand that if we are moving to a system which allows advance requests, you believe that the diagnosis has to be made that the incurable disease exists. That has to be found, correct? Yes, well, if I would correct what you said, if I may. I prefer not to talk about advance directives, but advance requests. Yes, you're right. I said that wrong. I had advance requests in my mind, and I translated it incorrectly into French. Second question. And what happens when an advance request is made and then the medical act and care, end-of-life care, have to be administered when the person is no longer capable of consenting? Right now, in the system and amendments that we have made, does it mean that people who are suffering from an irremediable death with reasonably foreseeable death can receive medical assistance in dying even if they no longer have the capacity, but they did have it when they made the advance request and then afterwards it's done? Or if they show any resistance, you cannot administer it? Is that what you would recommend as what should be applied in terms of the advance request? In other words, as soon as the patient or subject manifests any resistance, that the medical assistance in dying not be administered? Well, it's much more complex when you are dealing with advance requests because patients with cognitive disorders often will resist anything and everything. A bath, getting dressed, having their teeth brushed. So resistance to care is not something that I believe can really be interpreted as being a refusal of care. It's much more complex when you're dealing with people with cognitive disorders. I think we have to find or try to find some form of compromise between forcibly administering this to an individual who is physically refusing and eliminating the advance request completely. The compromise could be that when the person makes an advance request, they say in advance whether they wish the care to be administered even if they refuse it, or if they prefer the care not to be administered, the treatment not to be administered. This could be a compromise if the dilemma were to be resolved by the person themselves when they make their advance requests. Well, right now, in the system, if there is any resistance, it's a stop. Yes, but it's not the same thing. When you're with somebody who's at the end of life, and often these people become unaware and unconscious, so it's very rare to resist because they're going to be unconscious, so they won't resist. They won't be aware of what's going on around them. This is not at all the same circumstances. Dr. Lucy, I have to apologize to cut you off, but we only had 3 minutes. Very well, thank you. And now, I don't know if Senator Wallen is there, but if so, you have the floor. No? Okay. Then over to you, Senator Mégy. 3 minutes. Thank you. My question is for Dr. Pajot. You talked about an error from the person filling in the form. If they made a mistake filling in the form themselves, is that the individual making the request? But isn't it filled in by a healthcare professional? Do they assist or support the person filling it in? What kind of error are we talking about? Well, the error of autonomy that's not well guided, and autonomy has to be in the current moment. I can say now, oh, in 10 years, I want to buy a desert island and be alone on a desert island, but maybe I'll end up with a big family and friends. Would I still want to go and end my life alone on a desert island? Maybe my example's ridiculous, but we don't know what the future holds in store for us. So can we really foresee dementia and the behavior and psychological symptoms associated with it? Some people think so, but we have to show the data, the evidence, because we don't know what the future holds, when you make a diagnosis compared to when the person has the dementia. Thank you. Second question for Dr. Lussier. Some witnesses have talked about possible safeguards and said that if a person has made a request at point X in life, there should be some renewals or the request should be revisited. What do you think, and how frequently should it be revisited? Well, it's difficult to assess frequency because we don't know how much time is going to take place between the two. I think it's important to reassess to ensure that, as Dr. Pajot was saying, the individual, people change. Dr. Pajot was talking about, I don't know what philosophical terms you used, maybe the ego that changes or the self that changes over time. You have to allow the self of the people with cognitive disorders to also evolve. So it's important to do this at the time of the request, but also to be reevaluating it regularly, frequently, to be sure that there hasn't been a change of mind, because some people will get used to their condition and will get used to long-term care and will get used to a different life and will no longer wish to have medical assistance in dying. So I think in terms of how frequently or what the interval should be, I can't say, but it's important to repeat the exercise to be sure that their wish doesn't change. Thank you. Thank you very much. You have 13 seconds. Not enough for another question. But we do have time for a second round, so I'll give you the floor again for a second round. Thank you, Mr. Garneau. Mr. Ellis, you have the floor.
Thank you, Chair. I appreciate that. Thank you again to the witnesses. A couple of issues, and I'll start with Ms. Iftin, if I may, and I may cut you off, and I'll try to be gentle with it. But I'm wondering, you talk about a misdiagnosis in the prison system, which I think does present a unique scenario in terms of how certain behaviors may be perceived. But have you ever thought about safeguards that may be required should this be a decision made for the penal system?
Absolutely. The first safeguard is to make release mechanisms available and other options available. We cannot divorce that discussion. So as long as there aren't viable release mechanisms, it's going to be very, very difficult to safely implement MAID in prison. That's not a question. There has to be other options. So while I am in support, I'm not in support of MAID. I'm not in support of MAID on itself. So the first safeguard is that there has to be options and there has to be oversight. I am very concerned about the lack of oversight that currently is associated with how MAID is implemented, the fact there is no review of the MAID cases, the fact that CSE has no obligation to conduct mortality reviews, and the fact that there doesn't seem to be any kind of experts on the parole board to discuss other options when somebody applies for release.
Thank you very much for that. I appreciate your brevity. To Dr. Lussier, our colleague, Ms. Mr. Arsenault talked a bit about improper care given in certain diagnoses. And certainly I believe that all of us have heard the case of a veteran of Canada being offered MAID in what would appear to be a significantly inappropriate case, of course, without access to mental health. So I think that's certainly something to consider. You know, you talked a lot about difficulty in judging if people with dementia or other neurocognitive decline have capacity. You know, is this going to be left on an individual basis all the time, or is it going to be left to all individual physicians to help make that decision? That becomes very difficult. And again, I'll come back to that. You did speak briefly about safeguards. What safeguards do you think we need to have in place for advance requests?
Well, I think we have to make sure that the advance request is done with the person knowing what they are requesting, to make sure that they know all the options available. I think we have to make sure that when or if they're implemented, they're also done in a proper way, and that we have a review system to make sure that there's a good medical care and that there is good implementation of the advance request. I think these are the main safeguards that we have to put in place.
Merci. Alors, l'autre ronde. Oops.
Next round. You have 3 minutes. Thank you, Senator.
Professor Iftiin, I'm just wondering if you could walk us through the process for someone wanting to seek MAID who is currently in a penitentiary. If you could just walk us through the steps, and if you could maybe comment on how many cases we have seen over the past 5 or 6 years since MAID has come into action.
Cases, the answer is I don't know, because when I filed for a Freedom to Information Act, I was told that's too private to answer after 1 year. So the lack of accountability and oversight is so significant that we cannot access any reliable information on these issues. That's how serious the matter is. The Office of the Correctional Investigator reports 3 cases of MAID somewhere 2 years ago, but we don't know how many people asked. The procedure itself basically says that the individual has to apply, is going to be assessed by the prison physician. So it's not an independent assessor. It's somebody that works in the prison system. And if the prison physician says that the person is eligible for MAID, then they are going to be seen by a second assessor who should be somebody independent in the community. But if the prison physician says, no, you're not eligible, the assessment ends there, which my understanding is quite different from what happens in the community. So that is briefly the process itself. And then if the MAID is being, if the individual receives MAID, again, the matter ends there. Normally, CSE has an obligation to conduct reviews of all the deaths that occurred in prison, natural or not natural, and obviously the causes that have led there. They are exempted by legislation to do so in cases of MAID, which of course is a significant problem in terms of oversight and in terms of the lack of safeguards for how these assessments are done, what else is being made available, what are the alternatives. So right now, as it stands, it's particularly problematic, as I said, even leaving aside the discussion of lack of release mechanisms.
Is the initial assessor, is that person qualified to provide MAID assessment?
I don't know what qualifications they have. They are the prison physician. So whether every prison physician is otherwise qualified or not, I don't know. That's not the problem. Is my guess is that they are not always qualified. It would be hard to believe that that's the case. But also the other issue is one issue of, I would think, independence. And I think there is a problem when the prison physician is somebody that's working on contract for CSE.
Merci.
Monsieur McGregor.
Mr. McGregor, you have the floor.
Minute.
2 minutes.
Non, ouais. Excusez-moi, Monsieur Thériault là-bas.
My apologies, Mr. Theriault. 2 minutes as well. I won't take it personally, Madam Co-Chair. I respect the list. Dr. Lucier, perhaps we could pick up where we left off before. Could you tell us about happy dementia? Well, we're reticent to talk about happy dementia, but what we refer to as happy dementia are people who are happy in their daily lives, who do not demonstrate any objectively evident suffering, who may not necessarily recognize their family or may not know what day or date it is, but in the here and now, they're happy. And they'll be happy to eat and to participate in little activities. They'll be perfectly satisfied and happy. So should those people should they be considered to be suffering sufficiently to implement an advance request for MAID? That's a good question. Some people will say, yes, they're happy now, but before being sick, before being ill, had they seen themselves in this condition, had they said, I don't want to live that way, if I'm in that situation where the only thing that I like to do is to go eat and be in the chronic care institution, long-term care institution, and participate in those daily little activities, that's existential suffering for me, and I would prefer to have medical assistance in dying. But maybe people adapt, and then they become happy. And so when we talk about refusal before, it becomes even more difficult to administer medical assistance in dying to somebody who seems to be happy and who doesn't remember having requested it several years before. So there's the difficulty with happy dementia. Well, if the care team cannot undertake the assessment process until a third party says, well, based on the will of the patient or the individual with this condition, I don't see why we would have an assessment. In other words, it's not the care team that's going to come one day and say, oh, we think that there should be an assessment. So that whole issue of happy dementia, it could also be part of the discussions in the repeat assessment process that you were referring to earlier. I think it should also be part of it. 5 seconds. When the person makes their request, they could state whether they wish to receive medical assistance in dying if they are in happy dementia. Thank you. And now over to you, Mr. Garneau. No, I believe it was Mr. McGregor. Oh, I apologize. Mr. McGregor, over to you.
Thank you very much, Madam Co-Chair. Dr. Lucier, I'd like to turn to you. You heard my previous intervention with Dr. Pajot, your colleague, and I had previously mentioned the testimony we had about how there can be clearly defined, objectively accessible criteria, and that may be in response to his concerns about interpretation. I just want to invite you to offer any comments on that, but also, I know you stated you would like advance requests to be available post-diagnosis, but do you have any opinion on how often that advance request should be renewed or reviewed so that we can be sure that the patient's opinion is not changing as they progress?
Pour la première question, pour aller selon ce que
For the first question, along the lines of what my colleague was saying before, are there objective symptoms? There could be, yes. I think if an individual says that if they're incontinent for feces and urine, that could be an intolerable suffering for them. And that could be, of course, not just a one-time occurrence, but if this were to be a continuous condition, if a person identifies that as an objective suffering, that could be a criterion that could be used in order to apply the early request. But how often should this be reassessed? I think it really depends on the individual and the course of their developments. the idea is that the choice should be stable in time with all of the changes associated with dementia. Thank you. And now, I turn the floor over to my colleague, Mr. Garneau. Thank you, Senator Mégy.
Colleagues, this brings our panel to a close. I'd like to sincerely thank our witnesses today. Ms. Iftine, thank you for shedding some light on the issue of MAID in the context of correctional services. Et au Dr. Lucier et au Dr. Pajot, merci d'avoir.
Dr. Lucier, Dr. Pajot, thank you for your presentations and thank you for answering our questions on this extremely complex subject dealing with the advance requests. So thank you for giving of your time this evening. And with that, we will suspend for a few minutes so that we can prepare for the next panel. Thank you.
carry on till 8:37 to have the full hour. I'd like to make a few comments before we get going, just administrative ones. To the witnesses, please wait until I recognize you by name, or my co-chair does before speaking. And a reminder that all comments should be addressed through the chair. When speaking, please speak slowly and clearly. We have translation, and that's a challenging task to translate, especially when people speak too quickly. So please don't speak too quickly. Interpretation in this video conference will work like in an in-person committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. And when you're not speaking, please mute your microphone. With that, I would like to welcome our witnesses for panel 2 who are here to discuss advance requests. We have with us this evening Dr. Blair Bigham, Doctor, Emergency and Critical Care Medicine at McMaster University by video conference. We have Dr. Dorothy Pringle, Professor Emeritus at the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto, also by video conference. And we hopefully will have our third panelist this evening, Sandra de Montigny, who will join us hopefully in the next few minutes. But we will get going at this point. So thank you for joining us. We'll begin. The way we do this is that each of the witnesses will have a 5-minute opening statement, and then we'll move on with the questions. So Dr. Bigham, if you're ready, please go ahead. You have 5 minutes.
Good evening, bonsoir. It's a privilege to speak to you today in my capacity as an emergency and ICU doctor, as a scientist, and as an author of a book on how shifts in technology and society have changed our relationship with death. Please accept my apologies for attending this meeting while on call in an intensive care unit north of Ottawa. I was invited to appear before this committee after I had committed to serving patients this evening during the Ontario Health Human Resource crisis. Should I have to step away for a medical emergency, I hope it is only briefly. In my 17 years as a paramedic and doctor, I have seen many people die. But the people I see die are usually different from those we think of when we talk about palliative care or MAID. Emergency department and ICU patients sometimes die slowly from chronic disease like cancer or congestive heart failure. Other deaths come quite suddenly and unexpectedly after a car crash, a severe infection, or a ruptured aneurysm. For many of my patients, they hope to recover fully and live a long life. To accomplish that, teams of doctors, nurses, respiratory therapists, and other professional lifesavers jump into action using medicines and machines, scalpels and science to avert death and pull people back from the cliff's edge. But at the time we initiate resuscitation, the outcome is far from certain. Sometimes no amount of drugs or devices can save a life. Sometimes I cannot make you better. A modern dilemma has emerged with advances in medicine that has led to a crisis in dying. For some patients, after a while, it becomes clear that the machines keeping them alive cannot help them recover, but are preventing them from dying. Tethered to machines that have failed to restore their health, they exist in a liminal space between alive and dead. Many of us would not want to exist in this way. Individual values and predetermined wishes are already used by hospital teams to place limits on medical interventions, set goals for care, and alleviate pain and suffering. The rub comes in that the well-intentioned application of technology to save a life often fails to do so, but prevents patients from crossing the finish line to die with dignity and peace. Some might argue that pragmatic similarities between MAID and our current practice of withdrawing life-sustaining technology exist. For some, withdrawal of technology results in nearly immediate death, and comfort is maintained with various medications. But for others, withdrawal of technology results in a lingering that is undignified and sometimes distressing. Even when technology is removed, death, though certain to come, can be slow to arrive. It's my opinion that Canadians deserve to have a say in their own ending, because now, for the first time in human history, technology can and does prevent nature from taking its course. There is likely a larger role for MAID to play in acute care settings, where consciousness and the ability to consent is often compromised. Adjacent to the question of MAID is a broader one of how we can better inform Canadians of their choices during unrecoverable critical illness and engage their loved ones in discussions around end-of-life values before tragedy strikes. The challenge I believe this committee must consider is one that all Canadians must contemplate. Prognostication is often uncertain and always complex. Knowing when the likelihood of a successful recovery falls short of the medical team's capabilities and a patient's own wishes is fraught with difficulty. I hope today I can assist your deliberations around how advanced directives regarding medical assistance in dying can contribute to alleviating this modern-day death dilemma so that no Canadian dies too soon nor dies too late. Thank you. Merci beaucoup.
Thank you, Dr. Bigham. We'll now go to Dr. Dorothy Pringle for 5 minutes. Dr. Pringle.
Thank you. Well, I'm a retired registered nurse with a background in psychiatric and gerontological nursing. I've practiced and taught nursing students in both acute care and long-term care facilities. And I had the pleasure and the opportunity to be a member of the Council of Canadian Academies expert panel on medical assistance in dying. And I was on the MAID for advanced requests. I'm strongly supportive of MAID and advanced requests for MAID. I think patients with devastating terminal illnesses that do not affect their cognition, for example, most types of cancer, cardiac conditions, amyotrophic lateral sclerosis, gain a sense of control and comfort by determining when and under what conditions they will be relieved of pain and suffering. More challenging are diseases that result in dementia and the loss of cognition that require someone other than the patient to take responsibility for initiating MAID based on conditions specified by the patients. The Netherlands experience indicates that MAID following patients' loss of competence is rare but difficult. Most patients with dementia exercise the MAID option while they are still competent. Now, practices to enhance effectiveness of advanced requests have been identified, but we have little understanding of how effective they are. So I think a critical issue is the management of advanced requests when the patient is cognitively impaired. We have some advantages to bring to this. We have lessons from the Netherlands, which has excellent oversight and very good data. And we have experience with MAID across Canada on which we can draw. Thank you.
Thank you very much, Dr. Pringle. And I believe I see Ms. de Montigny with us. Alors, Madame de Montigny.
Ms. de Montigny, you have 5 minutes to give us your opening statement, and after that there will be a question period. So if you're ready, please go ahead. Are you on mute? I see that you're on mute, Madame de Montigny. Can you hear me now? Yes, we can. Very good, thank you. So I was saying that contrary to my previous habits before I received this disease, I'm going to read this text. Otherwise, I just won't be able to get through it. So it's with a sense of urgency in my mind and in my body and my heart that I am making this presentation to the Special Joint Committee on Medical Assistance in Dying of the House of Commons of Canada. In introduction, I'd like to read an excerpt from the expert report on medical assistance in dying for situations of loss of capacity for the Quebec government. It says, Sandra de Montigny was only 39 when she was diagnosed with Alzheimer's. Her father died of this disease at the age of 53 after suffering symptoms which greatly affected his dignity. Ms. de Montigny suffers from the hereditary form of Alzheimer's, which is a more rare and serious form. This young woman has a family, a spouse and 3 children. Her youngest is 12, her oldest 20. Her children have a 50% risk of having the hereditary form of Alzheimer's. concerned by the fate of people such as herself who were affected by neurocognitive disorders and the experience of their loved ones who are supporting them every day. Sandra de Montigny participates in research projects on the disease and speaks publicly to demystify it. She grants interviews to make elected officials and the general public aware of the whole issue of extending medical assistance in dying to people who have a disease which will lead to the inability to consent. And now it's a few years later. I'm now 43. And here I am giving a brief to the Joint Committee at the House of Commons. My motivation is to share my life experience with Alzheimer's, which is young onset Alzheimer's. I'd like to share it with you as a family caregiver and a person suffering from this disease. I'd also like to tell you about my vision for the future, a future during which, progressively but surely, I will have more and more griefs and more fears. I know what to expect because I saw it very close by for years, taking care of my father, Denis. Since I got my diagnosis in 2018, I've been focusing my energy on this, preparing my exit to make it as gentle as possible. It's better to try to find something positive here. I'm working to calm my mind and my brain that keeps getting lost and my heart that's so sad. I need to reassure myself for the future so as to better experience my daily life with its increasingly numerous trials and tribulations. I want to enjoy my last years of good life with a free mind and no fear. With my mother and my father, I supported my father Denis until the end of his life. He died at age 53. He carried the same genetic defect as his mother before him and her mother before her, and so on and so on. A 50% risk of genetic transmission. It's a toss-up. And given this genetic mutation, if it's present, the disease will develop in 100% of cases, and the genetic form develops early, in age 30 or 40, depending on which gene is responsible. That person will be a mother or father of relatively young children who will become caregivers. My 3 children are caregivers every day, and each of them also have at least a 50% chance of developing the same disease as their mother. And this weighs very heavily on young adults and on teenagers. I am categorical. Since I supported my father in his descent into the hells of Alzheimer's, I know that I do not want to go through what my father went through. It is out of the question. I don't want to end my life completely dispossessed of my dignity. I don't want to wander around day and night on all fours because I'm too exhausted, crying, looking around me lost or afraid, mumbling a few words which are so hard to understand, becoming aggressive with my children who I'll no longer recognize. I'm forgetting more and more, but those images of my father, 15 years later, they're still with me. I will only be able to forget them when I can calm them down by telling them that they're not going to recur yet again with me. Our Canadian policy is progressive and humane. Canadian citizens are asking for the legalization of advanced medical requests for medical assistance in dying, especially following a diagnosis of Alzheimer's, so as to be able to live my remaining life with more calm in my heart and my mind, to be able to fully enjoy the last days of life, knowing that when these people will have determined that their time has come, they'll be able to count on their representative to make sure that they can die with dignity thanks to their right to die. Thank you, Senators. It's been an honor for me to be able to share my experience with you and my opinion regarding early and advanced medical assistance in dying. Thank you. Thank you very much, Ms. de Montigny. Question now over to Senator Migy. Mr. Ellis, you have the floor.
Thank you very much, Senator, and thank you to the witnesses for being here on this very, very important topic for all Canadians. A very passionate speech, Madame de Montigny, and a difficult topic, and perhaps difficult questions, but I do think they're important. And again, very personal. If you're uncomfortable with it, I understand that. But how do you choose a time that your suffering has become too much? How do you come to that decision? Assuming you still have the ability to make that decision, have you given that some thought and perhaps discussed that with your healthcare provider?
Oui, en effet, je peux répondre.
Yes, can I answer in French? Yes. Yes, it's a question I still ask myself. And increasingly, Well, I think when I won't be able to recognize one of my children, somebody in my family, more specifically one of my children, because I know it's going to happen. And to me, that's too much. You have to think of this at some point. It's not easy. That's what I think now. But honestly, I haven't completely decided yet.
Very much for that. I appreciate it. Of course, the difficulty then becomes, sometimes in dementia we have fluctuations in our abilities to recognize people, and have you given that some thought as well? You may have a good day, may have a bad day. Is it a combination of those things? And again, I apologize for asking these questions, but I think it's important that we understand from someone like yourself. And thank you again for being here.
C'est très gentil, ne vous gênez pas. Ce sont de très bonnes questions.
That's very kind of you, and please don't be shy. They're excellent questions. Well, you're right. In Alzheimer's, there are good days and bad days. But I would like to hold on to my basic values. And that's, I know that I don't want to lose my dignity by having to depend on everybody for my basic needs. For example, somebody to feed me, somebody to change my diapers, somebody who brings me to sleep because I don't understand the difference between day and night. Certain points of repair. And at the risk of leaving too soon, of dying too soon, even though I adore my life, but I'd rather have criteria that make me end too soon rather than leaving too late, at which point I wouldn't have been able to decide and they end up in a situation where I'm no longer able to consent.
For you, Madam Chair, I appreciate the answers. I do have another question, if I might. We've heard from other witnesses that perhaps life may change. I understand you have a child who's 20. And again, I apologize for asking this, but I think it's important I understand this. If your child of 20 were to have a child, which would be your grandchild, obviously, do you think that might have any impact in your decision making?
C'est une très bonne question. Vous savez quoi?
That's a very good question. And here I am, age 43, and I've been a grandmother for a year already. So life takes care of things sometimes. I'm spoiled. I have a first grandson, and I'm happy that he's there. But at the same time, as I said earlier, there's this dilemma for me between, well, how long do I want to live the good times versus the risk of those times which are really tough and that ultimately will, for me at least, mean that there's absolutely no dignity left. Unfortunately, I don't want to take the risk. Yes, I'll have to make difficult choices, but to risk to be caught a prisoner of my body for years and wandering around and being aggressive, I don't want that. So unfortunately, maybe I will leave too early or a little bit earlier than I would have wanted to ideally leave.
A final question through you, Chair. Has your family expressed any discomfort with your decision, that they want you to be around longer than perhaps you might choose to be?
Non.
Merci beaucoup.
No, they all fully agree.
Merci.
Thank you.
Merci.
Thank you.
Va à Monsieur Arsenault.
Over to Mr. Arsenault. Thank you, Co-Chair, and thanks to our witnesses and to you all. It's so important to hear from you today because you're bringing another perspective for witnesses asking for advance requests. You are still so young, and that's cruel, but as you say, you're going to have to make a decision to go one day, and maybe too soon rather than too late. Some of our witnesses have spoken of ageism. In other words, people who are in favor of medical assistance in dying or advance requests, we're talking about ageism. In other words, they were against offering medical assistance in dying. What do you think? Do you think that you could be overprotected saying, oh, she doesn't really know what she's asking for. She doesn't really know what she wants. We have to protect her. What can you tell us about that?
Merci pour la question.
Thank you for the question. It's an interesting one. Well, I would say that's why it's so good to have an advanced medical assistance and dying request. Right now, my Alzheimer's is moderate. I can still think, I can still make decisions, and I can talk to you relatively fluidly. Now, if I have to think about what point in time it should be, when will I hit my limit? At least when I think it would be. I may be mistaken. It's better to let time pass. But then at some point we can't express ourselves clearly. So maybe what I say sounds stupid, but I don't want to put my destiny into the hands of the ends of Alzheimer's. And I don't want to put that destiny into the hands of somebody who would just allow me to be sick like that for a long time. My father ended he went fairly quickly. It didn't last that long, those tough years. But my grandmother, his mother, was in a neurovegetative state for 7 years. I am familiar with that. I have a lot of people in my family, several. Okay, you're familiar with that. I was going to ask you, if today you've been diagnosed as having Alzheimer's, if today advance requests were possible, is this something which would give you relief? Would you do this right away? Like, in other words, what would it change in your life if it were accessible today? You're right. Clearly, it would be a huge relief for me and for my family because they know how important it is for me. Because I could choose the point at which I believe it would be the best way to go. Or obviously, I'd rather go at age 80, but if we know that's not going to happen. My fear, I read a lot. I'm afraid that if it goes on for too long, then you pass that stage where the ability to consent disappears. And then I'd be caught, stuck in my body, and stuck doing unfortunate things to myself in order to end my life. And I don't want to have to get there. Thank you very much for your testimony, Madame de Montigny. Ms. Pringle.
About what's your thought about what you've heard from Mrs. de Montigny in your context of work? As a nurse.
As a nurse, well, I think her testimony is about all we need to know about how important it is to have advance requests. And I think she presents the biggest dilemma in the whole area of advance requests, and that is for people with dementia and where they are in favor of MAID. But again, if they choose, while they're competent, to take advantage of MAID, I don't think there's an issue. And that is the experience in the Netherlands, again, which has a lot of experience with this, that very few of the patients there who are cognitively impaired, in fact, go on to the point where they cannot make the decision and they rely on others. Most of the folks who are cognitively impaired make that decision before they are no longer competent. And so I think as a legislation, we need to think through whether or not we will continue to permit advance requests after the person is cognitively impaired.
Merci beaucoup. Thanks a lot, Mme Pringle. It's all the time I have, so merci beaucoup à tous les témoins.
Thank you very much to all witnesses.
La prochaine question.
Thank you very much to all witnesses. Next question, Mr. Thériault. Thank you, Madam Co-Chair. Ms. de Montigny, you ended your testimony by saying that it was an honor for you to meet with the members of parliament and the senators. I would like to tell you that the honor is quite reciprocal. And it's not the first time that I've heard you speak, but maybe we're closer now. It's the first time that I've been so touched and so moved by what you said. You said things that were very powerful. You said, my mind is getting lost and my heart is so sad. I'm a prisoner in my body. I don't want to be caught and stuck as a prisoner in my body. So what I'm trying to determine here, what we're trying to determine, is what the best conditions would be so that somebody who has a major neurocognitive disease that's degenerative would be able to confidently live as long as possible, and that their will would be respected, even if they no longer have the capacity of expressing their point of view, because everything necessary for a third person to, together with the care team, begin the process would have been done in advance. And if the care team says, no, we don't think that it's time yet, well, there's no urgency. It would ultimately be done. But what has touched me so much tonight is that, to a certain extent, you're saying to us, or I'm reading it this way anyways, you're saying, I am not going to wait to be incompetent. I am going to shorten my life. And as a lawmaker, I would like to be competent enough to be able to prevent you from doing that. Go ahead. No, you. What makes you think that you're going to have to do this before being incompetent? Because I don't have an advance request. But at the point where we said, yes, you can, would that change your point of view? Obviously, it would allow me to go on for longer with the disease. Because otherwise, right now, if there's no advance request possible, if there's no advance directive, there will come a point where I don't want to take the risk that it's gonna go too far and I'll miss out. Whereas with an advance request, I will have clearly established what's acceptable for me and what isn't. And I've talked to my family about this. I've talked to my children, and it's okay with everybody. Ideally, I would like to live for a relatively long time. I mean, I want to live through part of this disease. I don't want to go at the very beginning. It's okay for me to be lost and to need help, but what I don't want is to go through the last phase of the disease where people are completely dependent, unable to communicate. I don't want that. I've seen it up close, and I don't want it. And that's what I want to clarify in an advance request. So yes, it would give me more time. I don't want to put any pressure on you, but if there's no advance request that's accepted in Parliament, well, unfortunately, I am going to have to choose to go before moving into that phase, because otherwise I'll be stuck. I heard this very clearly. That's why I'm so touched. I think that we can find a way, because when it comes to such intimate decisions as the decision to be able to have the free choice over our own death, I don't see why the state should get involved in this, especially in the conditions that you've experienced. You're very much aware of what's in store for you. Your children are too. We see in your testimony that this is a process that's really a family process. There are people who can see suffering everywhere, and they see people taking advantage of the people who are suffering and who call into question people's attitudes. There may be some paranoia about people who are questioning this, where you're saying you're just a human being who has the right to decide with a free conscience as to the timing that I'm going to go, and I want someone to help me with that. And I'm prepared to help you. Thank you. I'm happy to hear you say that. And you're right. It's become a family process. So the first time that I talked about this, first time I talked about advance requests to my children, it made perfect sense to them. To them, having no quality of life and being in bed for 3, 4, 5, 10 years, I don't want that, and neither do they. And, you know, they might have the disease too. They have a 50% risk. And they said, we'll make the same decision as you if we get it. Mr. McGregor, 5 minutes.
Co-chair, and thank you to all of our witnesses. And Madame Desmontigny, thank you. In all of our conversations around this committee, often when we've been speaking about dementia, most of the testimony we have heard has been from professors, from people in the medical profession, who can speak about the disease generally and of specific cases in a slightly abstract way. But I think your testimony is very powerful because you're here as someone living with dementia. You know what's coming your way, and you are pleading for autonomy over your own life. And I think that's a very powerful statement. I wanted to ask you a question about the stigma that is associated with dementia, because we have heard several witnesses talk about, you know, when people first receive a diagnosis of dementia, they may not be familiar with the disease intimately, but they do know generally that it's a disease which goes down a very negative path, and that might influence their decisions. You, however, have a very intimate knowledge of the disease because of your family history, and I think in your opening remarks, you talked about that you wanted to avoid the descent into hell that your father went to. So you understand this disease very well. Can you maybe talk about, you know, your own personal experience, like with the stigma associated with the disease, but also as a person who is intimately familiar with it? I think you offer some good insight into that.
Merci.
Thank you. You said all kinds of interesting things, but I think that they've gotten a bit mixed up in my mind. But you're right. I have seen this disease from the inside out. And I wouldn't wish this on anybody. But to accompany somebody, to take care of somebody at the end of life with Alzheimer's, somebody young, because often the elderly will often die before they end up in that end-stage condition of that disease with such horrible symptoms. But young people don't die. My father was a great athlete, so he didn't die young, or wasn't going to die young for that. Who would be comfortable saying, if I have an Alzheimer's diagnosis, I'm going to continue right to the very end? I personally do not feel that way. Now, we did get good care, and he did have good support. You know, suffering could be seen in his eyes, in his face. He was always tense. He would look at me and cry, but he couldn't speak anymore. He was crawling around on all fours. He licked the floor. I mean, in my mind, most human beings would not like to live with that, and I don't anyhow. And knowing that I want to avoid that. Now, other people may have a different vision of the end of life, and that's okay. I think ideally, everybody should be able to take the path that is appropriate for them based on what life has given them. Well, life has given me a poison pill gift, and I have decided to take a stand and to act proactively and work on trying to decide to have a dignified end of life with Alzheimer's, which is not really the case right now.
And we've also had some witnesses who have been concerned that if advance requests were permitted, there might be some difficulty in interpreting the wishes. Do you have any concerns? Do you have any concerns that if we allowed advance requests that you would be able, I think you're of the opinion that you would be able to clearly articulate the conditions of the disease that you would want medical assistance in dying to be triggered. Can you offer any personal thoughts on that, those concerns we've heard earlier?
Très intéressant. Je vous...
Very interesting. Well, it's no secret that I am quite familiar with this area. I had been working in healthcare, and then I was taking care of my father, so I'm familiar with all of this. Most people aren't necessarily, and it can be complex. I think in the healthcare network, we have people whose mission it is to support people during the complicated parts, and the steps to be taken. We have social workers, and that's their mandate. We have psychologists who could also help, to understand things. And I think these people are very helpful. I have a psychologist, I have a social worker. I speak freely with them about what I'm doing with respect to the Alzheimer's. And it feels good to me. And if I have any questions and I can't get an answer, they'll go and look for the questions and tell me the answers. It's important for people to be able to access these services. We know that in the health milieu now, it's hard to get care. It's hard to access care. But people have to be able to make an enlightened choice, looking at all of the possibilities. I think we need qualified and skilled professionals. And now I turn the floor over to Mr. Garneau. Thank you, Senator. And now 2 questions from senators. Let's begin. I'll ask the question again. I see Senator Dalphond is there. I'm going to assume that Senator Kutcher is not with us. So let's begin with Senator Dalphond. 3 minutes, please. Thank you, Co-Chair. Thank you, Dr. Bingham and Ms. Pringle and Ms. de Montigny for being here with us this evening. Your testimony is very important to us. My question is for you, Ms. de Montigny. I'm going to ask you a tough question. But I'm asking it because some people have said to us that in Alzheimer's, you come to a point where there's a happy dementia, that the self has changed, and that you can be in a situation where you're in a happy dementia. Did you experience this? Is this something that you accept? Can you say, yes, a happy dementia should be a phase that I should go through before, or that anyone should go through before coming to medical assistance in dying? When you talk about the last stages, when you have aspirational pneumonia and et cetera, all kinds of problems. Excellent question. Yes, you're right. There are often professionals who talk about happy dementia. To be quite honest, I don't believe in it. Happy dementia is symptomatic. It's a symptom of a disease that's being expressed. It's not that the person is happy. It's the fact that there's nothing in the brain, the neurotransmitters are deregulated, and so they're manifesting behaviors of joy, perhaps, but that doesn't mean that's how they're feeling. It's just what's coming out. And honestly, I find it sad. I've heard some healthcare professionals who are involved in medical assistance in dying saying that when you see a happy dementia, people are happy. They're content. Well, we don't know. We don't know. I know right now today, I can tell you that this behavior for me, well, I'll feel like I've lost my dignity if I do that. If I can't recognize my children, if I cannot go to the bathroom by myself, if I can't eat and feed myself, these are things that are objectively verifiable, they're observable. So to say that somebody who's happily demented, I don't know. I think this is a concept that may be pleasing to certain caregivers, to think that people are happy that way, or they're content. I don't think we can make any assumptions for there. So that's why I would like the advance request. Thank you. Well, if somebody, you were saying somebody should go to a further stage before having medical assistance in dying? Well, I think different people could have different decisions in terms of which level of symptoms they would be willing to have. Thank you very much.
Senator Wallen for 3 minutes.
Sir, I did not hear you. Were you speaking to me, Mr. Garneau?
Yes, Senator, you have the floor for 3 minutes.
Thank you very much. A brief question to Sandra, and again, thank you for your comments here tonight. I just want to ask whether you have created your list of symptoms that will be unacceptable to you, and have you discussed that with family and caregivers, and are they in agreement?
Oui. Oui à toutes ces questions.
Yes to all of those questions. When my ability to take care of my own basic needs will be altered significantly. In other words, when I won't be able to feed myself, if I won't be able to toilet myself, to wipe myself, to me, that's autonomy, that's independence. Now, maybe my sense of pride is different, but I don't want to share that, especially knowing that I have a degenerative disease. It's not going to get better. If I had a situation where it was temporary, and temporarily I had to have people involved in these more intimate areas of care, but ultimately I would recover, that would be something I could do. But knowing it's just going to go from bad to worse to worse to worse, quite personally, I see no reason to do that. And my children, I was going to say, my children all agree, and they have said to me that if they were to experience the same thing, they would do the same thing.
All right. I would like to hear from Dr. Bigham and Dr. Pringle on this. We're living in the world right now without advance requests, but to both of you as medical professionals, is Sandra's approach acceptable to you, that she has a long record of saying these are her views, she has experience, she's prepared to write it down, the family or the substitute decision makers have agreed? Is that acceptable in any way now, or would it absolutely require an advance request in order for her wishes to be met on receiving MAID?
So we'll start with Dr. Bigham. You'll each have
you.
about 25 seconds.
Thanks.
Specifically to the point of dementia, my understanding currently is that it would be unacceptable to provide MAID without a clear short duration of life expected. And so for that reason, advance requests would be required. We frequently see, advance requests may not be perfect, but we frequently see patients, and Ms. Demonier actually said this, that she would rather die too early than too late. And we see this in our technology-enabled world, where people forego medical technology that could save their life because they are afraid of rolling the dice and ending up in a worse situation where they are dependent on others to survive, or where they're unable to communicate or contribute to society. And so for that reason, advance directives are useful far beyond dementia and cognitive decline, and in other areas of chronic illness and perhaps acute illness as well.
A quick word from Dr. Pringle.
Go ahead, Dr. Pringle. Would like to hear your view.
Okay. At this point in time, what Ms. Montigny has told us, she would not be able to get MAID. And I think the only issue that we haven't talked about is when you are cognitively impaired and you have this list of things that indications of when you want MAID, then somebody else has to initiate it. And it's got to be a family member. But as a family member isn't available, then it's probably going to go to the medical team. And the difficulty that's been experienced is for somebody who doesn't know that patient well to initiate MAID. And a problem if there's resistance on the part of the patient because they are cognitively impaired and do not understand what's going on. I think in the case with Ms. Montigny, it's a perfect situation in a terrible circumstance, in the sense of family that are on board and would be prepared to follow her directions. And when that occurs, I think that that's the intention of advanced directives.
Thank you, Dr. Pringle. Nous irons maintenant à la sénatrice Mégy.
And now, Senator Mégy. Thank you, Chair. I have a question for Dr. Degang. You work in intensive care, and that's not where you're going to see a lot of people with dementia who are going to ask for advance requests for MAID. But in your intensive care, many patients will see technology being withdrawn. Some will die and some will have their lives prolonged. In your experience, do any of them say to you, I would have liked to be able to speed things up, or could there be a possibility of requesting MAID? Have you had that discussion between you with any patients who you were withdrawing from technological support?
I frequently, first of all, it's very unlikely that at that stage in someone's illness they're able to communicate with me. But I very often hear from family members along the lines of, can we speed this up? It's torture us watching this go on and drag out. For many patients, when we withdraw technology, they die quite quickly. But for others, they can linger for hours, for days, sometimes for weeks. But the outcome is certain. And this can be very distressing for families, and occasionally it can be uncomfortable for patients. And so for patients who require technology to have a shot at life, but for whom that technology then fails, there is certainly a role for assisted dying.
Merci. Une question pour Madame.
Thank you. A question for Ms. de Montigny. First of all, I would like to thank you so much for your words here and your true personal experience. I know that you've gone on speaking about this, and I'm sure you've met with families who have had roughly the same experience as you had. How do they see this? Are they saying, "Oh, I would have liked to have my mother had my mother been able to ask for this," or would they say, "No, I would have liked her to stay with me for longer"? What have you heard? What have you heard when you met with other people? Thank you for the question. Through my approach, in terms of the last phase of Alzheimer's, I am a spokesperson for the Quebec Death with Dignity or Dying with Dignity Association. So the people that I meet are often people who've already thought about this and who want to die with dignity. So I can talk about them. Earlier we had an annual meeting, and several people came up to me, and they would touch my arm, and they looked at me with tears in their eyes to say, "Thank you so much. That's what my mother wanted, and she wasn't able to get it." Or, "Thank you so much. It reassures me because I've just gotten a diagnosis of Alzheimer's, so I'm encouraged to hear what you had to say." There are people who don't agree, but obviously they weren't there because it's an association which has its goals. But, I received lots of positive, encouraging comments. People are relieved. There's a beginning of some relief. Obviously, there are all kinds of things in store for them, but at least they have the hope of ending their lives with dignity, not the way the people close to them had. Thank you very much, Ms. de Montigny.
This brings our panel to a close. I'd like to thank Dr. Blair Bigham and Dr. Dorothy Pringle for being with us this evening and for providing their opening statements and also sharing their expertise with us. Et en particulier,
and a sincere thanks to Ms. de Montigny. As many of my colleagues have said, your testimony has been so powerful and so moving and so eloquent, I would add. Clearly, you have given a lot of thought to these issues and to the questions that we asked you this evening, and all of this will be of great use to us in our deliberations.
To our three witnesses, and this will bring our panel to a close. The meeting is adjourned.
Merci.